let's talk a little bit about the data that supports using RFA for cancer because of the fact that we don't have it yet in this country. How are we collecting that data, and when do you think we'll actually have it?
It depends upon how you view the data. Okay. So we do have a little bit of an egocentric bias. We love to see data from our own country.
We sure do.
We love to see it from institutions that we know and that we love and that we know do great work. For an FDA approval, you have to have, before you ever start, before you ever enroll a patient, you have to have a protocol which is already approved for the purpose. So the FDA reviews it to say, well, is this experiment, is this trial going to show us what we are intending to find out about this treatment, whether that's a medical procedure, a device, or a drug? That's always the thing. To get FDA approval, you need pre-approval before you ever enroll a patient in a trial. And then we have these different phases that we go through to ensure that. And so a lot of the developments that we've had come from other countries where it's not so rigorous. Now, that's not to say it's sloppy work, but sometimes that process we have in the US is so daunting financially that it's just not done. So it could be that we end up using RFA routinely for small thyroid cancers without FDA approval. There's lots of things that aren't FDA approved, which are pretty much standard of care. The question then comes, when are we satisfied with the data? And if you look at the data that is accumulated so far, it is all super positive. But I have not seen any data on advanced thyroid cancers or aggressive thyroid cancers, because right now it seems foolish to go there. When you have a high cure rate, it's kind of unethical to give somebody an experimental treatment. And you'll see this with drugs. There's some really good drugs that help slow down advanced thyroid cancer that's past the idea of curing from an operation. All of those medications were developed on patients which had failed standard therapy. They were never developed on people who hadn't had standard therapy. So we know that there are tyrosine kinase inhibitors, for example, that slow down the progression of uncurable thyroid cancer. But we didn't withhold the regular treatment from those patients when we put them in those trials. Right. And because we have high cure rates with thyroid cancer, it's going to be hard to sort of cross that bridge and say, gosh, if it works for 1 centimeter, when do we start trying it on a 2 centimeter? And when do we try it on a 4 centimeter? It's hard to give up high cure rates. I think with small thyroid cancers where the consequences of it failing mean you can still have surgery. So I think we'll get a lot of data in the next couple of years here at stateside for those. But we also have all this data from elsewhere, which is super, super positive. Okay. So realize that if you were to do an RFA for a small thyroid cancer now, you're doing it off label. That doesn't make it illegal, right? It just makes it off label. And both the doctor and the patient need to have a discussion that, hey, this isn't an FDA approved, this is not the standard of care. We're going to vary from that a little bit, but we do have positive data that show that RFA for the right selected candidate could be a really good option. And in my mind, a better option than that observation idea, that active surveillance idea, which is being practiced all around this country right now. And of course, no FDA trial on that, just highly regarded institutions that are doing research trials. And it's looking pretty good for active surveillance in the right selected candidates. Even there, what you'll see is the people doing those studies are very selective about who they allow in. They don't allow in a large thyroid cancer that's already spread. Right? They are highly selective as who they enroll in this trial where they're comparing active surveillance to surgical therapy. The researchers that are undergoing this are going to be very meticulous about this to make sure that that data is good, right? As a researcher, you never want your data to later on be proven inaccurate. Those studies will come along. They'll be slow in the United States, at least a couple of years, I would think, from here. But we have a lot of good data already that's pointing the way to say, yeah, this is going to be highly effective if we choose the right people for it. You
Mhm.
know, we don't try to overextend what we know.